Hello and welcome. I'm Jim Carroll. I'm the CEO of the diaTribe Foundation. Thank you for joining us. Our conversation today is about a topic that is rarely discussed, yet unfortunately all too common among people with diabetes, chronic kidney disease. People with diabetes are at a higher risk for this serious complication, and the goal of today's discussion is to ensure that we all have the knowledge and the tools to keep our kidneys healthy. We have an outstanding group of panelists assembled today who will share valuable information on how to detect kidney disease early and what you can do if you're diagnosed with chronic kidney disease, including a discussion of some of the newest therapies. We'll also learn about some of the disparities that exist in detecting and treating chronic kidney disease and how they can be addressed. Before we get started, I'd like to express my absolute gratitude to our sponsors who make this event and all of diaTribe's work possible. A huge thank you to our generous presenting sponsor, OneDrop, for their leadership and support. OneDrop is at the forefront of digital health and working to keep people healthy before problems arise. And thank you to our gold sponsor, Abbott. They do so much to improve the lives of people with diabetes and for making CGM widely available. And thank you to our dedicated silver sponsors. I'm gonna get this right: Medtronic, AstraZeneca, Dexcom, Dompe, Lilly Diabetes, Novo Nordisk, Provention Bio, Sanofi, or some people call it Sanofi, Vertex, Xeris, and Sealant. Yes, thank you all. I'm now very pleased to introduce an important friend of diaTribe's, David Lee Strasberg, who is usually using his superpowers behind scenes at our events, but today he's going to be out in front moderating today's panel. In addition to being a longtime advisor to diaTribe, David is the creative director and the CEO of the Lee Strasberg Theater and Film Institute. David has presented at our D-Series conferences. He's presented at ADA scientific sessions, at industry seminars exploring advocacy, patient perspectives, and how to create transformative change. He lives with type 1 diabetes and has for the last 36 years. So without further ado, I turn you over to David. David?
So I am a little bit embarrassed, but also quite privileged to be able to tell you that after 36 years of living with diabetes, I've been educating myself, I've been diving into the field, I've been improving my glucose control, and frankly, I receive great medical care. I'm really blessed in that way. And I have never talked to anyone about my kidneys. And this, despite the fact that chronic kidney disease, we're going to refer to it sometimes as CKD, is actually one of the most prevalent and harmful complications of diabetes, right? Approximately 1 in 3 of us, 1 in 3 adults with diabetes has CKD, and kidney diseases are the 9th leading cause of death in the US. So thank you, Jim, and thank you to diaTribe for creating this space for a really badly needed and I think long overdue conversation, at least for me. For most of history, actually, doctors have lacked effective tools, right, to address kidney disease. And like so many things in our life, I think if we feel powerless to change something, often we prefer to simply either ignore it or push it out of mind. I think this happens for both patients and doctors. And fortunately, though, now, like, we have some new tools, right? And they've come online and they can help us prevent, treat kidney disease, along with a whole host of related diabetes complications. And with the new therapies, I'm hoping that maybe we can begin to look into this room that has been dark for a really long time. All right, and we can begin to shine some light in there. And for the first time, maybe ever, I can say that if we can detect chronic kidney disease, we can actually treat it, right? And certainly delay or even prevent like the tragic impacts of the disease, including extreme measures like dialysis. Right? So in our conversation today with some tremendous experts in kidney care, I'm going to ask the questions that all of us here, we all need answered in order to get some clarity, right? And I think some hope about how we can understand like this disease, what the future looks like, and how we can keep all of ourselves, like the ultimate goal, how we can keep all of us vital and vibrant and healthy. So before we dive in, let me just give you a quick rundown of the event itself. In just a moment, I'll introduce our 4 panelists for the main discussion, and I'm going to ask them some questions. You'll excuse my ignorance on the topic. I'm going to be learning right along with you. But then you get your turn. All right. So we'll be pulling questions from the audience, but you need to use the Q&A tab. So right there on the right side of your screen, there's a Q&A tab. You can add your questions there. All during the talk, we have a team going through culling those questions to make sure that we can present them to the panelists. And we're going to get through as many of those as we can. Also, there will be poll questions going up in the tab right next to that. It says polls. Thank you in advance for answering those. They really do help us. They help us to understand you and your experience and eventually to create a better event for you. Also, after the panel is complete, I hope you'll stay online for the community networking, which is a time for us all to sort of sit together more informally and to visit the expo booths. So let's jump in. Let's get to our panelists, right? First, our first panelist is Dr. Rachele Berria. She's the Vice President and Medical Head of U.S. There you go, welcome. And U.S. Medical Head of U.S. Biopharmaceuticals at AstraZeneca. She has a much longer title than me. And there she leads the U.S. medical team to ensure scientific leadership and patient-centered approach throughout the organization. And Dr. Berria views diabetes and other chronic diseases as the condition to be managed, right? To be cured, to be prevented through significant population level change. And I know we're going to want to hear a little bit more about how that happens, right? But also through evidence-based algorithms and innovative therapies. And I'm eager to hear from her about her work in developing these therapies and that can prevent and treat kidney disease and what she sees as the future of kidney care.
Thanks for having me, David.
My pleasure. My pleasure. Next, we have Jane DeMeis. There she is. Jane is a diabetes and kidney disease patient advocate. She lives with chronic kidney disease and diabetes, and she volunteers her time in a whole lot of ways for the advancement and research of CKD. She's also a certified kidney coach. She serves as a peer mentor and an ambassador for the National Kidney Foundation and American Association of Kidney Patients. She's also a national ambassador for the American Heart Association and the American Diabetes Association's program, No Diabetes by Heart. So she's got a whole lot going on here. And we're thrilled that she's here with us to give her very important perspective as a person managing her kidney and diabetes health every day. Welcome, Jane.
Thank you. I'm so honored to be here.
Next, we have Dr. James Gavin. There he is. Dr. Gavin is a clinical professor of medicine at Emory University School of Medicine and a former president of the ADA, American Diabetes Association. Dr. Gavin is also a distinguished member of many organizations, a whole bunch, including National Academy of Medicine, American Association of Clinical Endocrinologists, and the American Association of Physicians. He is also the CEO and Chief Medical Officer of Healing Our Village. And he has committed his life's work, really, to helping people with diabetes live healthier lives, especially in underserved communities. Dr. Gavin, welcome. You're muted there, Jim, so I'm going to ask you to unmute. There we are.
Thank you. It's a pleasure to be here with this distinguished panel.
Our pleasure to have you. And there's always got to be one, right? We're going to hope that that's our big technical snafu of the day, that's where it stops and ends, right? Finally, we have Dr. Joseph Vasily. Dr. Vassalotti is a nephrologist. For those like me who have to learn some of these things, that means kidney doctor. And he's Chief Medical Officer of the National Kidney Foundation. He's also a clinical professor of medicine at the Icahn School of Medicine at Mount Sinai in New York City. By the way, Mount Sinai in New York City is where I got diagnosed with diabetes many, many years ago. And at the National Kidney Foundation, he focuses on the implementation of evidence-based clinical practice guidelines in chronic kidney disease, including the National Kidney Foundation's Kidney Disease Outcomes Quality Initiative. We're going to have you unpack some of that as we go through, Dr. Vassalotti, sort of what all that means. But he's also worked with the CDC to help them identify individuals at high risk for kidney disease in the US and with the National Institutes of Health to bolster their research on primary care for kidney disease. He is an expert in kidney care, obviously, and I'm really interested to hear more about his work at the National Kidney Foundation, particularly, and his perspective on some of these new tools, right, of how we're treating and preventing this particular population of kidney disease in people with diabetes, which is such a prevalent area. Welcome.
Great. It's wonderful to be here. And I love this kind of discussion. Kidney talk. It's one of my favorite things to talk about. Looking forward to it.
We all have something near and dear to our heart, right? Well, I guess if the nephrologist couldn't be really excited about the kidney talk, then we're all in really big trouble. All right. But anyway, let's jump on in here. Dr. Vasalotti, let's just start with you to set the stage for us a bit here. So we know that approximately 1 in 3 people with diabetes has kidney disease, right? Just at a basic level, why is chronic kidney disease so prevalent among people with diabetes?
Well, it's important that people living with diabetes understand that kidney health is part of the care of diabetes, and that better care of diabetes can prevent kidney disease from happening in the first place. And if kidney disease is detected, better care of diabetes and kidney disease can help patients do better and live fuller lives. So looking forward to talking about that more.
Sure. I'm gonna risk the science geek side of me and wonder, like, so how does diabetes actually lead to kidney disease? What's the correlation there, or the causality?
Well, I think it's complicated. I think that, in short, I would say that poor glucose control contributes to diabetic kidney disease. Diabetic kidney disease also tends to occur in people who have high blood pressure as a comorbidity, and that we don't exactly understand why, but it seems like there's a population of people with diabetes. About 40% of people with diabetes end up developing kidney disease, and some people with diabetes don't develop kidney disease throughout their trajectory and their lifespan. So I think that the precise reasons are still being worked on, but we're starting to understand with things like biomarkers and other tests exactly what the causes are. But I would say microinflammation is one of the things that probably contributes to diabetic kidney disease and kidney damage. And some of that is can be predicted with biomarkers and other testing.
So you mentioned high blood pressure, like hypertension, right? Are there any other factors or high risk factors that contribute to kidney disease?
I think it's important that when people have diabetic kidney disease, they have an increased risk of cardiovascular disease, and there's an interaction between diabetes and kidney disease and cardiovascular disease, and that when we treat people living with diabetes, we want to prevent kidney disease from getting worse, but we want to also prevent cardiovascular disease. Heart attacks, strokes are more common in people with diabetes, and also heart failure is a very important complication of diabetes and kidney disease that we can actually prevent or reduce the hospitalization complication.
So already we're starting to see, like, there's this whole array, right? Diabetes is connected to a lot of different things. By the way, diabetes is not always the starting point, right? But it does seem to be in the middle of this whole bundle of challenges, health challenges. But Dr. Gavin, let me ask you, this is common, right? He's talking about 40% of people with diabetes having chronic kidney disease. It's a common complication, but it's not discussed an awful lot, right? It's not discussed as much maybe as things like heart disease or blindness. Even I hear about amputations and a lot of these things. So why do you think that is?
Well, despite its common occurrence, David, CKD represents an enigma in the universe of complications or concerns of diabetes. It's not been talked about as frequently as eye disease or amputations as long-term complications in poorly managed patients. And one of the reasons may be because the problem of impaired vision and blindness is more easily visible, no pun intended, and it's a more immediate and palpable kind of outcome. And the same can be said for amputations, which is one of the historically associated complications of diabetes that's known to leave affected people more diminished. Again, no pun intended. This CKD has not historically enjoyed the kind of cause and effect relationship with diabetes. As Dr. Vassalotti just inferred, it was always felt by some people that folks had diabetes and then developed kidney disease. We have let this fundamental relationship fly below the radar, and we've certainly not given chronic kidney disease and diabetes the focus and urgency that it's due, especially since it's one of the early common complications that can be predictive of cardiovascular complications and death, perhaps. And more importantly, this is an oversight that we need to correct, because early intervention can do so much to halt, even reverse the progression of CKD and diabetes. And it's time to give this complication the time and attention that it's due as an important, treatable, and yes, preventable issue in diabetes.
Yeah, there's a lot in there I want to unpack that we're gonna move through, I think, as we talk. But Dr. Berria, I know you know, we keep talking about this whole sort of collection of issues, right? He raised heart disease and all these other ones. Tell me a little bit about both your understanding of heart diseases, which ones are common in people with diabetes and chronic kidney disease, but also maybe how this related group of complications of diabetes, chronic kidney disease, cardiovascular disease, how they all sort of come together in developing new therapies.
Absolutely, David. So I look at our body as a beautiful and complicated machine. And so we have all these organs that have a specific function, but at the same time, they all rely on each other for our body to function well. And the relationship between diabetes, CKD, and heart disease is one great example of the way these organs are all connected, right? And so when kidneys don't work well, then waste products build up in the body. And so more stress is put on the heart that needs to pump harder to get blood to the kidneys. And to your point, this can lead to heart disease, which manifests in different ways. There's either buildup of plaques in the walls of the blood vessels, or there's a heart attack caused by lack of blood and oxygen to the heart, or heart failure, as Dr. Vassalotti was mentioning. That happens when the heart muscle doesn't pump blood as well as it should. Now, heart disease, as you know, is the leading cause of death in the United States, and it's also the most common cause of death, actually, in patients with CKD. I think the good news is that with all of these diseases, since they're so intertwined, we can prevent and manage them all at once because the risk factors are the same. And then to your other question on how these groups of conditions come together when we develop new therapies, at AstraZeneca, we have one key value, which is, simply put, we follow the science. And I think there's no better example of how that concept applies to new therapies. GLP-1 agonists, maybe I'm dating myself, but I do remember the first prescribing information for a GLP-1 that had weight loss as a side effect. And now these drugs are actually tested for their specific effect to treat obesity. And same thing for SGLT2 inhibitor, specifically for dapagliflozin, that we discovered first that it improved hemoglobin A1C, and then that it improved cardiovascular death. But then also heart failure could be improved, and then now kidney disease could be improved. And to me, the lesson is that we wouldn't have been able to do that if we didn't take a 360 degrees perspective where we put the patient at the center instead of treating the single condition and finding treatments for that.
Yeah, we're already getting now into, we can see how this conversation has a lot of complexity, right? There's a simple conversation here, and yet it's all this connection. And Jane, I know you had a long journey to getting diagnosed with kidney disease, and I know that you've learned a whole lot of lessons along the way. But just trying to staying in this notion of both understanding what the disease is and where each of us is in relation to it, what advice would you give to people who are sort of, for those who are at risk for chronic kidney disease, either because of hypertension, heart disease, all these other risk factors, but for them to navigate the health system and to get the care that they need? What would you offer there?
Well, first of all, I would say that everybody should have a baseline of kidney function at some point early in their life, because if you don't know where you're starting from, you can't tell if you've got a decline. So I think as part of your annual physical, run a renal panel. It's a simple test. Then you know how you're running and how things are working for your kidneys. for those who have history of diabetes and cardiac issues, it should be automatic for the doctor to check your renal function every time they check your blood levels for everything else. It just should be automatic. And for patients who don't really understand kidney disease and the connection, that conversation should happen very early on with the doctors and the providers saying, you know, you don't have anything now and that's good, but let's be aware of it and stay on top of it, because early detection is the best solution.
You know, and I only know Jane now a little bit, but I know one of the things that I can tell even in this conversation is like that the patient can also originate that conversation.
Absolutely.
Right.
Yep.
That it's, and I hear that like embedded into that is this belief of like, you advocate for yourself too.
Yes,
right?
absolutely. Mm-hmm.
Dr. Gavin, she talked about early diagnosis, so important. You brought it up as a critical issue. What's the benefit here? Like what changes with early detection?
Well, one of the most important insights that we've learned, David, about diabetes and its effects on various organs in the body is that kidney damage starts early, that you've heard, and it's pretty silent. Now, in many populations, almost 10% of people already show evidence of kidney damage by the time their diabetes is diagnosed. But we're talking about a problem that we know how to manage. We know how to reverse it. And now we have these new tools and treatments that can effectively and safely treat not only the kidney disease, but the diabetes and the blood pressure problems that contribute to the development and the progression of the kidney disease. So it's crucial to remember that kidney disease and heart disease are strongly interconnected. What happens in one strongly predicts what's likely to happen in the other. Now, what that means is that it's not surprising that kidney disease and heart failure, as you've heard from Dr. Vassalotti, are among the earliest complications seen in diabetes. And so the rules have changed. Providers are now being asked at the time of diagnosis, at the time you assess a patient with diabetes to make a treatment decision, you need to find out, is there chronic kidney disease present? Is there underlying atherosclerotic cardiovascular disease? And if the answer to either of those two questions is yes, which one of them predominates? So now if you know that, we now have tools that give us an opportunity to start early in the treatment of a complication like kidney disease. And these tools can reverse and halt the progression of this complication. At the same time that it's treating the diabetes, that's important, and provides help with the blood pressure and protects the kidneys from further damage. So I'll say what Jane just said as well. In order to address a problem, you first got to know that it's there and at what level of severity, because that's what determines the urgency with which we address that problem and which tools we bring to the fight. Let me close by saying, you know, you want to know that there's a splinter crack in your foundation or a small leak in your roof when it's just small. And that case, you can act aggressively on it and keep it from getting worse. And that's what we want to try to do with kidney disease.
Yeah, and actually, you know, you went over my non-expert head on some of the conditions, right? But in a way, as a patient, we don't need to know all those things. Right. I'm glad that somebody knows those things. But, you know, Jane talked about, just make sure they run a renal panel. And I would say we'll explore a little bit as we go along further, think about what that language would actually be for a patient. Right. As someone who couldn't take notes fast enough to write down what Dr. Gavin just said, what would you actually ask for? Right. In the doctor's office. And I think that's something I want to explore a little bit. Even now, Dr. Vassalotti, to talk about like what those tests are. Right. So somebody who's not expert could simply say to a doctor, by the way, did you check this? Right. So how do we actually detect chronic kidney disease today? What are the tools, Dr. Vassalotti?
Great. And we hope you'll start to think about this just the way you think about your annual checks, maybe with an ophthalmologist for eye disease, or maybe with a podiatrist for problems with your feet, or your cholesterol testing every year. And of course, I'm sure you're having your hemoglobin A1C for diabetes control tested frequently. Think about the kidney test, blood test, and a urine test, every year at least. And the American Diabetes Association, the National Kidney Foundation, and others recommend annual testing for all people with type 2 diabetes. And for people with type 1 diabetes in general, because type 1 diabetes is usually precisely diagnosed earlier, that annual testing is recommended after 5 years of type 1 diabetes. The blood test is a test of kidney function. The urine test is a test of kidney damage. The blood test you can ask for is called creatinine. The normal creatinine is about 1.0, and higher numbers mean lower levels of kidney function. So,
so basically higher, so higher numbers. And is this the UACR? Is that what that is?
This is the blood test for creatinine kidney function test, and higher means lower kidney function. And so it's a little bit of not intuitively obvious. So that's why we use the estimated GFR. And you can think of that like a percentage of kidney function. It's not technically a percentage, but you can think of it like a percentage. And I ask my patients to think of it like that. And that's how we educate patients with the National Kidney Foundation. And 60 or more is considered to be normal for that. And the lower the percentage or the lower the kidney function, the generally, of course, the more severe the disease. A nephrologist is always recommended when the GFR is less than 30, for example. And deceased donor kidney transplant wait list usually requires a GFR of 20 or less. And patients often need to start dialysis when it's 10 or less, just to give you a sense of the different levels of kidney function. And the test you mentioned, David, is called the UACR. That's the urine albumin creatinine ratio. I think of that as a kidney damage test. The creatinine and the eGFR are kidney function tests. The higher the eGFR, the better.
So if somebody asks for kidney function, if somebody were to come in and say, "Oh, can you check my kidney function?" they'd probably end up with the creatinine or the eGFR.
Yes.
Got it.
Yes, and you can ask for those specifically too, though. You can ask specifically for a creatinine test and for an estimated GFR test.
Yeah. Actually, I'm really glad to even hear your numbers. I know everything depends in medicine, right? It depends on a lot of risk factors. But literally, in preparation for this panel, I went back into my little health record because now it's all online. And I was like, what the heck were my eGFRs? And they're in there. And I was worried because I was like, because it says under 90 is like flagged. So it's in the big bright red letters, right? That I was like at 84 and I started to freak out a little bit. And I'm thinking, well, I'm going to see this nephrologist literally in the panel, right? And I see my doctor on Thursday and I'm going to bombard her with, I'm down to 84. What do you got, right? But it doesn't sound like necessarily, you're talking about 60 is like a more urgent threshold.
Less than 60, yes. And of course, we're talking generally, and this is not a substitute to talk with your individual clinician. I'm just trying to give you some general.
Totally. Trust me, I'm going to go to my clinician right away and be like, okay, what's the deal? Right? But it's nice to have some ballpark, right? When somebody says they're not worried, you can go, oh, what's the number? And you hear it and have some context for that. Or they can explain the context to you, right? That's also useful to say, like, well, given all these other health things, I am concerned or I'm not concerned, right? I think patients, right, are entitled to this. Are there any other common or tests that aren't commonly done that should become part of the routine?
Well, yeah, maybe I took too long for kidney function, but there's a kidney damage test that's called urine albumin to creatinine ratio. That's a UACR. So you want the ratio. So a lot of times patients get scared because they see urine creatinine. That's usually a very high number. That's not that important. And the urine albumin concentration is not that important. It's the ratio. It's the albumin divided by the creatinine, and that gives us a ratio. And that number, it's usually milligrams per gram. Mg divided by gram is what you'll see on your lab report, David, hopefully if you look. And hopefully, Jane, you'll see the same. And you want to see that less than 30 is considered to be normal. Between 30 or 300 is moderately elevated. Above 300 is considered to be severely elevated, and above 2,000 is what kidney doctors call nephrotic albuminuria, proteinuria, and that's a very severe level of albumin in the urine. And albuminuria, or increased levels of albuminuria, are a common sign of diabetic kidney disease. They can occur even when the GFR is normal, David. So like your GFR sounded like it was in the 80s. You still would want to know what your urine albumin to creatinine ratio was to see if you had any kidney damage. And we think of this like blood vessel damage. the micro-inflammatory changes of the small blood vessels in the body. That's how we think of the test. And even if your tests are normal, your GFR is above 60 and your urine albumin creatinine ratio is less than 30, then we would want you to have that tested at least every year to see how you're doing.
So I mean, now I'm understanding when you were talking before about microinflammation, right? This is also where diabetes, we often think of diabetes problems in these really small capillaries, right? Small areas of blood flow, tight blood flow. And this is also a problem that occurs in the same region, which is why might be some of this interaction. It's interesting. Jane, let me ask you. So now we throw out these things, EGFR, UACR. Now you're a pro with these numbers, right? When did you first learn about them? Again, I know you've had a rich journey here, for better and for worse, a rich journey. When did you become aware of them? And is knowing the numbers, has that changed any of your conversations?
So I was diagnosed in 2009, and I was at that point around a 3B, which was around a 40 some odd level there. And it bounced around there for probably 3 or 4 years. And to be honest with you, I knew nothing. I had no conversations about it. My rheumatologist was the one who said, "Hey, by the way, did you know your kidneys crashed?" And I'm like, I had no idea what was going on. It wasn't until I started passing kidney stones and things started to decline that I really started to have the conversations. And I also want to let you know, I was not diagnosed with diabetes. I didn't get diagnosed with diabetes until 2016. So it could happen either way. You can have the diabetes and get the CKD, or you can have the CKD and have that be a complication of that. So I had to do a lot of my own self-education, but that was also partially I was working in the healthcare system. So I was lucky to get some education pretty much early on. But the conversation didn't happen back in the original time.
Yeah. Well, by the way, now we are lucky to have you, because for folks who aren't in the healthcare system, right, they get the benefit of your learning in it. And so, again, I really appreciate you being part of this kind of conversation here. So, Dr. Gavin, I know it depends. And when should a patient be concerned with their numbers?
Well, David, it does depend, but I'm hearing a few things that I want to highlight for a second. And one of them is the reference that you made about going back to your own clinical records to see what your EGFR was and what perhaps your creatinine was at the time of your last evaluation. So one of the things that I constantly challenge my patients and trainees with is that you as a patient have the obligation to become an expert in one case of diabetes and all of its ramifications. And that one case is yours. I have responsibility for becoming an expert in hundreds, if not thousands, but you have the responsibility for doing that in one case. So there are some things that I want to make sure that you are capturing. One, you've already heard from Dr. Vassalotti that there are thresholds. So patients need to know which numbers are important and what distinguishes good from bad, okay? Now, you've heard about tests that distinguish kidney function from kidney damage. So the first thing I want to ask patients to do, rather than worry about the number, is, are the tests being done? And are they being done on the recommended schedules? For example, has your creatinine been measured? And has your EGFR been determined? Did you get a urine test? Because some offices are not set up to do urine tests, so they're not measuring urinary protein. So if the tests aren't being done, you're not going to generate the numbers that patients can ask about in the first place. So patients need to be aware that these tests need to be done, okay? And they need to know at what level have I departed from the zone that keeps me out of trouble. Now, you talked about the creatinine. We know what the ranges are for, and let's say this. Patients need to be aware of what's normal for you, because there are variations. Men, for example, have different thresholds than women, okay? Things like EGFR can be affected by a number of different things: creatinine, age, body mass, gender, And the question of race we'll talk about a little bit later. So you need to know whether or not you are in the range that is expected for you. The urinary albumin levels you already talked about. And the one thing I would point out is that patients need to know if their numbers are in a range that's considered not good, you need to get it confirmed. One test is not going to be sufficient. They need to have confirmatory tests done. So when patients hear a number that's in a range that is not good, for example, in that 30 to 300 milligram per gram range that Joe just talked about, you need to get that repeated. If it's greater than 300, well, you know that that's severely elevated. That also may need to be confirmed, but you already know that there's a problem there. Okay. Now, there are many places that you can learn what these numbers are, how they are measured, what's good, what's not good, and how these numbers can be changed. And I think those are the themes that we should be emphasizing for patients. Patients have to ask. If they don't ask, and if they don't write stuff down, and keep track over time, then unfortunately these numbers won't be used to their optimal benefit. So I'll just leave it at that.
I will push back on you just a half step, which is I would hope that a patient wouldn't have to ask, because sometimes you don't, right? You'd hope that the doctor can bring it up. However, since, as you say, like, we are responsible, in the end, it's our body, right? We are responsible at some level for our health, that if it is not being brought up, then we have the power to ask. And I think that is also part of finding the right relationship with your health.
I would go so far as to say you have the mandate to ask, because you know, one of the things that we haven't said here, David, and we should, is that not all providers are at the same level of familiarity with many of the concepts that we are talking about here.
Yeah.
So,
well, actually, I want to follow up on that, because Dr. Berria, I know you've looked at that a lot, right? So what's going on there? Like, how often do these things actually get done, right? I think we know instinctively they're not being done enough, but what's happening in terms of the attention that variation among clinicians?
Sure. So I don't think the screenings are done as frequently as they should, especially when you consider both EGFR and UACR, even though we know that when clinicians test for both, they're actually more prone to act. But then, having said that, David, you gave us a beautiful example. You checked your lab work and you did have your EGFR. And so the reality is that sometimes in a routine blood work, the EGFR is done, but nothing is, it's prompting no action, even if those numbers are low, even below 60, as it was said before. So I think we have multiple issues here. The first one is properly screening for CKD, where there's room for improvement. The second issue is really translating screening into diagnosis, which is not, a given, as the colleagues were discussing. And the third issue is translating the diagnosis into proper treatment. And so I can give you an example. There was a recent article published in the Journal of the American College of Cardiology, and this was a large database of over 350,000 patients hospitalized for heart failure. And what it shows is mind-boggling. So the use of guideline-driven medical treatment, instead of going up, it was progressively lower with decreasing EGFR, which is absolutely counterintuitive, because those are the patients that really have the highest risk for mortality and cost more to the society. So I joke with my team and I keep telling them our biggest competitor is the clinical inertia here, and really clinicians that really need to act faster. And I understand, especially in primary care, that clinicians have a lot in their hands and multiple conditions to manage. And maybe before the excuse was that besides treating the risk factors, there was no treatments for CKD. But now that we have tools, I hope that this will make it a little easier. And I also hope that now that the kidney profile is part of what Dr. Vassalotti will explain further, I'm sure, part of the HEDIS measure, that clinicians can be reimbursed for, there will be more attention devoted to chronic kidney disease.
And all this, now we're starting to dig in here into treatment and when we get it, how do we, like in practice, right? I see in chat people are like really looking at some of these numbers, and I like it. The goal here, of course, is we're trying to prevent heart disease, right? But the elephant in the room, in a sense, is dialysis to me, right? It's the thing when you hear kidney disease, if you hear the word like dialysis, I don't know. For me, if someone said dialysis, it's like a momentary freak out, right? Of like what? So, Dr. Vasalotti, just give us a little bit of context, like what is dialysis and what point people need it.
Great. I think if you have kidney disease, we talked about if you don't have it, get tested annually. If you have it, then you want to know how severe is it? How low is your estimated GFR? How high is your urine albumin creatinine ratio? And what is your risk of kidney failure or the need for dialysis or kidney transplantation? Kidney failure means you need dialysis or kidney transplantation to live and live healthy. And in general, kidney transplant is probably the best treatment for kidney failure. And we don't do that enough in this country. And preemptive kidney transplant is probably the best treatment, I think, for many patients with kidney failure. That means that they never have to start dialysis, that they have a kidney transplant first. There's three kinds of dialysis in general. There's home dialysis, which has two types, and in-center hemodialysis. And this is replacement of the function of the kidney with dialysis. And I think that's probably all I'll say. There's a lot to unpack in this conversation.
Yeah.
And I'll just say kidney.org, the National Kidney Foundation website, has more about this. And diaTribe, I know, has a website, and there's some useful information there. So I encourage everyone to look there. But I think, David, the most important thing to say is dialysis is not a destination. We can do better for people living with kidney disease by better care, better control of diabetes, better control of high blood pressure and lipids, and also there are kidney protective medicines that hopefully we'll talk about.
Well, I'll tell you, I'm supposed to be a moderator here, but that was the best segue I've ever heard for Jane, right? So Jane, I know you were diagnosed, what did you say, 2006, you say?
2009.
2009.
Yeah.
And I know you were told that you needed dialysis, right? Tell me what's happened since that. Like, tell me what about that journey with dialysis.
So as a typical kidney patient, what happened was I had a steady decline and moved into stage 4. And in 2017, I was like, I've had it. I've had enough of this. This is not working for me. And so I went back to the nephrologist in 2018, and she told me then, because of my track record, I'll use that word, my progression of my kidney failing, that I should be preparing for dialysis within 6 months. And I said, no, not going to happen. So I went and saw a renal dietitian, and I changed my lifestyle. I lost about 38 pounds and became healthy, and got involved in learning more about the nutrition and lifestyle changes to improve my kidney. And things are going great until COVID hit, and then food sources became a little bit wacky. So I put a little bit back weight on and went into stage 5. And I said, not going to do it. Not going to do it. Went back and saw the renal dietitian and went plant-based back in February. And I actually have improved my GFR. I have dropped my creatinine very much so, and I feel fantastic. So there are a lot of things that you can do to stay off of dialysis for as best as you can. Some people, there's nothing much you can do, but for a lot of patients there is. One thing I did want to address especially to Dr. Gavin, that you said that the patients should be asking these questions. One of the problems with kidney disease, which is different from a lot of other comorbidities or other diseases, is there are no symptoms. So the patient may not even know that they have kidney disease because they're not noticing any changes. They're not having highs and lows with sugars and sweats and all the other things that happens with diabetes or heart palpitations. You don't know you have kidney disease. So sometimes people just don't know to ask.
Can I respond there?
Please, please.
Again, this actually pushes the notion of why I insist that when you're diagnosed with diabetes, your challenge is to become an expert in all aspects of your disease, because there are things that you won't know unless you do the kind of deep dive that becoming an expert requires. And one of those things is that you learn that, you know what, there are things going on with me that don't declare themselves early on. And so I need to ask, are we doing the kinds of tests that are required for me to know whether or not some of this early stuff is happening to me? That's the platform that I'm pushing, because we're talking about the word here is early. We're not talking about, advanced or later stage, but early is when we really want to make sure that patients seize control and put themselves in position to maintain control over what they know and what happens to them.
I love this conversation in particular, by the way. While I will encourage, I have a minor pet peeve. I want us to be careful about medical information on the internet. I like connection among patients, and I like getting opinions of what people's experiences have been. And there's some really great resources when you're saying, oh, I have hypertension. Is that, am I at risk for anything? Like, you want to use credible resources, not just, people in your Facebook group. Right. And that there are some tremendous resources out there online, certainly National Kidney Foundation, diaTribe, in various disease states, you can look at that, and it's available in a way that never was before. I want us to get to talk about treatment here, because James is introducing his things that have changed for her. But first, I think we need to acknowledge something here, which is dialysis, which she is not started, because she has transformed her relationship with that disease and at least changed its trajectory. Yes. And we know that both chronic kidney disease and dialysis, specifically the need for dialysis, is not like that impact is not uniformly distributed, right? So I think it takes a moment here for us to look at, like Dr. Vassalotti, what do the numbers tell us here? Like, what are the populations that are disproportionately impacted, both by kidney disease and dialysis need?
Yes. So of course, people with diabetes have a high rate of kidney failure. And I think I was just telling one of our residents today that dialysis is kind of like a 4-letter word in American culture. And that when people hear that word, a lot of times they don't hear anything we say, like you said, because they freak out about it. So we have to be careful about talking about it. A lot of education about it takes place over time in sequence. So it's not the first conversation. It might be the third, the fourth, or the fifth where you start to connect.
Actually, can I just interrupt for 1 second? I think it's a great thing to say, because we'll hear words, and you're right. I think as patients, we stop. Right, we will just stop. I mean, I know, like in my family, when I was diagnosed at 15, like my mother heard amputation and just stopped. Right, like it was hard for her to get anything past. Well, possible side effects, right? And it got to amputation, that was it. And I'm, thank goodness, whatever blessings I have, right? I seem to be doing all right. But it's this effort, this reaction of stopping is something as patients that we have to be accountable for. To say, like, oh, I don't get to stop here because I have to live in this body. So I want to keep going. And as you have both pointing out, like learning more. By the way, I think there are other words, trigger words too, right? I think dialysis is one. Insulin. We don't have to go off onto this topic, but I think insulin is one, especially in the type 2 community. Thinks it like means some sort of failure. And I think that it's actually a phenomenal tool for a lot of people. By the way, I think obese is also a word. It's like you get to obese and then like we don't hear anything else. All we hear is that we've been, stuck in some box somewhere, right? And I think it's important for us as patients to really stand in those moments and go, oh, so you're saying you think I need insulin, and then go and to slow down, get informed, and understand what's really being said and where you are with it, right? So sorry, that was my soapbox for a moment.
No, that's
you
good.
Can continue, please.
But David, I would say one thing though, I want to change the dynamic on dialysis as a fear explosion, right? It's also a great motivator. If we can take that fear of dialysis, just the way Jane has done, I think, in her life, and turn it into motivation to live a more healthy life and maybe take the medications more carefully, perhaps, maybe she'll have a better outcome. It sounds like she is doing much better already. So fear of dialysis can be leveraged to motivate the patient if it's done properly, if you can over time. That takes time.
I would leave that to an artist, meaning, maybe you are, right? I think different clinicians will have a different ability to navigate that. Yes, there's a carrot and a stick. Most people, I think, use the stick too much, in my experience among healthcare providers, right? And it's like you're going to, and what you've done, and we end up, as patients, feeling very heavy in that process of like, I have failed. And if something, like as you have pointed out, I think actually all of you experts have pointed out all these things we don't know.
We want to inform and empower. We don't want to judge. We want to inform and empower our patients. But you asked about inequities in kidney disease, and I didn't get to that yet. So I do want to be very careful that we do say that, you know, populations that self-identify as African American, Hispanic, Asians, Pacific Islanders, and American Indians all have higher rates of type 2 diabetes. And all of those populations have higher rates of chronic kidney disease and higher rates of the need for dialysis. And African American people, for example, represent 13% of the US population in the census, but they make up 35% of the dialysis population. And there, you can say similar things about the other groups that I mentioned, but I think it's important that we don't want to biologize race and ethnicity, that we think the reason for that has to do with social determinants of health, primarily, and things like where you eat and your ability to access physical activity, and maybe your engagement with an access to the healthcare system and the medications that we're going to get to. So I think it's important that we say that. Genetic ancestry, it may be somewhat related to that, but that is less important that we think than the social determinants of health. There's a lot to unpack in what I just said, so I'll talk.
Yeah, that's right. So, Dr. Gavin, I know you've done a lot of work in this area specifically. Like, he mentioned all these disparities and some reasons for them. Are there other things that occur to you?
Yeah, well, I think I should have just let Joe keep on talking, because he was really on track for all of the things that are important in this complex interplay between gender or genetic differences in the prevalence and control of CKD, risk factors like blood pressure or otherwise, but the role of social, environmental, and economic factors have gained greater attention as important elements in determining the pathway from risk of CKD to the complications of CKD and end-stage kidney disease. Now, many of these determinants, like obesity, diabetes, high blood pressure, endothelial dysfunction, or that microinflammation that we've been hearing about, and oxidative stress, these things are rooted in socioeconomic deprivations and the associated findings of those deprivations: segregation, substandard living conditions, limited quality of healthcare, health literacy, what you eat, the toxins you're exposed to, the frequency of health evaluations, the availability of insurance, access to medications that have proven benefit that we will talk about and hear about more a little bit later. And ultimately, things like where you are on the transplant wait list. So all of these are important issues that drive the disparities that we see in kidney outcomes. Now, this could be a long conversation, David, and I won't punish the time here, but the contributions of race are more difficult to assess. But it's clear that race and ethnicity capture a wide array of social and cultural exposures, because these are powerful determinants, in this country especially, on where you live, how you live, what you have access to. And we also know that race and ethnicity are correlated with genetic ancestry. And this is something that we may capture information about genetic variants that might have clinical significance in medicine and research. And so we're trying to do something here to strike a balance in terms of what do people self-declare in terms of race and ethnicity. I'm African American. That says nothing about what my ancestral DNA makeup, or what my variant profile will look like. That needs to be determined. But in determining that, those become tools that we now can use to tease out who in these populations are really at the most risk for some of these untoward outcomes. And that's one of the things that I want to argue for. I want to argue for caution in completely eliminating the capture of race and ethnicity in medical information that we gather, because I think we need those designations in order to lead us to the ancestry information that will tell us about genetic variants. Otherwise, we will never get to precision medicine. We will never get to personalized medicine, which is going to be genetically based decision making on what kinds of interventions and what kinds of therapies are optimal for persons across races and ethnicity. So I think it's a balance that we're trying to achieve, and it's a complex interplay here.
This definitely, I'm hearing the complexity at work in this, in both getting information, not overweighting it, right? Not giving it too much weight, but at the same time, you also mentioned this notion almost of like, an expert in the one, right? Like that's like, it's not just what your category is, but what your specific profile is, right? Which is all a challenge here in this conversation. But I do want us to think about, like, so I know on my EGFR, I literally have two different numbers on my EGFR. I have the African-American EGFR and I have a, non-African-American EGFR. Like that's what showed on my health record. I don't remember the exact wording. I think that might be the wording they used. But Dr. Vassalotti, I know at the National Kidney Foundation, you guys have been working with this notion of raceless EGFR. So just tell us a little bit about what that is and what you think it is intended to accomplish.
Yes, thank you. And there's a lot to unpack here. And I thank Dr. Gavin. That was a great discussion there. And so for me to summarize this is, was challenging. But I would just say in general that since the National Kidney Foundation with another organization called the American Society of Nephrology, September 23rd, have introduced a solution that is a race-free, so GFR. So essentially there will only be one estimated GFR for all. And we think that this will be good for society and good for medicine to get away from biologizing race, if you will. We'll still have to address race in terms of inequities, I think as Dr. Gavin mentioned, but there will in the future we're implementing this estimated GFR, and you should start to see that, David, hopefully soon in the future with your laboratory reports. And
well, it's interesting to think that literally you could get two different numbers depending on what you do, what box you check, right? That's an interesting thought. Go ahead, Dr. Gavin. I know you want to jump in.
But there is something else that's developing, and I think Dr. Vassalotti might comment on this, and that is that there's now an attempt to develop tests like the cystatin C assay, which will now is one of those proteins that will allow you to track. It's a marker, as you will, a blood marker that allows you to track what your kidney function is independent of race. It's across racial subgroups. And so I think we'll start to see emergence of things like that will help us to answer questions that we are concerned about without introducing this ambiguity of putting two different numbers on people's charts when that fundamental set of relationships hasn't really been solidly validated. So that's the problem with the EGFR, race-based EGFR. Yeah. There has not been the really solid correlation of what that number does for accuracy of diagnosis. You can actually have misdiagnosis. And that's why that number is suspect and why we need to be doing something differently. But that doesn't mean that we have to get rid of all elements of capturing race and ethnicity when we're looking at markers that predict certain health outcomes.
And I'm hearing that loud and clear. What I'm really getting there is there's a couple of different conversations, right? There's where I think the National Kidney Foundation leadership is about at a really large level of clinicians trying to get to look at the individual, right? And not to perhaps shortcut by adjusting a number through that. By the way, you don't even see the adjustment, right? It simply is reported as a number and no one gets to investigate. So I think at one level, I think it's a huge statement.
We know we're doing it right when we can use these things to predict, as opposed to looking back and making adjustments for a number. So I think that's what we are trying to do.
And perhaps the some of the bias, like I know Jane has in our separate conversations, Jane, you talked about sort of assumptions people make about you for a variety of reasons, right? And I think part of this racist EGFR is to remove some assumptions, some flat assumptions that don't have a chance to be challenged. Even as Dr. Gavin's pointing out, at a population level of medicine, we need to really be understanding things at a much deeper level. I think it's complex. And I guess maybe, Dr. Vasily, I'm just going to ask you the bottom line for a patient with regard to racist EGFR or not. What does that patient need to know to interact with the number when they go see their doctor?
Yeah, I think the most important thing to know is we don't pay enough attention to estimated GFR, whether it includes race or not, unfortunately. We need society, patients, clinicians to spend more attention to estimated GFR, to guide interventions, to help patients have better outcomes. And I think that's the most important thing. And I think having one number to focus on without race coefficients, I think will be better for society and will actually be simpler in some ways, and hopefully will help clinicians and patients pay more attention to estimated GFR.
Yeah. So this is all landing us to this place where it's probably maybe like the thing that I really want to talk about. Like, we have all these factors, right, to understand, to detect, early diagnosis of it, different testing things, understanding, all gets us to the question of what do we do about it, right? If we see numbers, what can we do? Dr. Berria, I want to start with you here in terms of obviously the SGLT2 inhibitor class has been, a huge movement in this space. Specifically AstraZeneca's Farxiga, dapagliflozin. If you don't think I had to practice that one, you're crazy. I say it like it's nothing. So what are the benefits here? Like what's happening in this space in terms of treatments that are out there today? Not just with Farxiga, but broadly in the space.
Yeah. Well, maybe for the people in the audience, to make it simple on how this new drugs work, they block some of the glucose and the sodium reabsorption in the kidneys. And so, simply put, because of the loss of glucose, the sodium, and water in the urine, there's a series of physiological adaptation that happens in the body, right? So the metabolism becomes more flexible, and FACS is used to produce energy. There's less inflammation in the glomeruli, which helps the work of the kidneys. The blood pressure improves, the vascular function improves, and really, I wanted just to mention that these discoveries don't happen just by magic. It needs commitment, and it needs a long-term commitment. And so what we have done is a program that is called DAPA-CARE, and I believe is the largest SGLT2 inhibitor clinical development program. We have over 35 clinical studies that were either completed or that are ongoing in 35,000 patients. And to your point on how the landscape look like, one of the most recent studies, it's called DAPA-CKD, and I think it's very appropriate to mention that in this forum. It was designed to evaluate the effect of dapagliflozin in patients with chronic kidney disease. And actually, we stopped it early because the benefit for the patients was so pronounced that essentially it was considered almost like unethical to keep patients on the placebo arm. And what we saw is that dapagliflozin or Farxiga, as you said, you pronounced it beautifully.
Slow that down. You said it was unethical. Just go slower on that so people can understand what.
Yeah. So the study had two arms, right? So the patients were randomized to either have the active treatment or the placebo. And at some point, the data monitoring board saw that the results were so striking that they decided to stop the study early. And what we saw was that dapagliflozin decreased the risk of kidney failure and also slow the progression of renal disease. And at the same time, there was a decrease in the risk of any cause of death. The other impressive thing is that we had two subgroups of patients. One group had type 2 diabetes. The other group did not have type 2 diabetes. And really, the effect was seen in improving CKD regardless of the presence of type 2 diabetes. So I think, it was mentioned before, we have now many tools in the armamentarium. I'm with Dr. Gavin's camp. It's the onus of every patient to be the expert of his or her own disease and ask for that. But at the same time, it's good for clinicians to really be up to speed with all these new developments and these drugs.
I'm still though a little stuck just because you put the word unethical in there. The comment is really like it was unethical to take people off of the medication because it was so darn good. Isn't that?
No, it was unethical to keep doing the study with some of the patients not receiving the active drug. And
I
so
see.
the trial was stopped early for that reason. So it was a good reason. That's why you want to stop the studies early, not
Right.
because undue effects.
Because people in the control weren't getting it, and that was essentially unfair to those folks.
Correct.
So
Correct.
interesting. Right. I just want to make sure we all hear that and understand that that's really huge. Also, as someone who lives with type 1 diabetes, I know I've had lots of dreams of SGLT2s that are going to change my life, right? Why aren't SGLT2 inhibitors, why are they not currently? They are not currently indicated for people living with type 1. I know that also came up in the chat as a question as well.
That is a very good question. So this, you're right. The FDA did not approve these drugs for treating type 1 diabetes. This route was tried, and the FDA actually a few years back convened a panel of experts. They voted negatively, and the reason was that they were afraid of the risk of diabetic ketoacidosis in these patients, and really their thinking was that this risk would outweigh the benefit that these drugs could bring in terms of, for example, increasing the time in range that patients with type 1 would have. Now, I don't know what my colleagues think, but I think it's also fair to say that in case a patient has type 1 diabetes and develop chronic kidney disease, since these drugs are beneficial in slowing the progression of kidney disease, maybe that risk-benefit equation in that case may shift, and it's worthwhile talking to the doctor.
Got it. So, Dr. Vassalotti, I know that you're obviously an expert, and we think of sometimes the problems here are coming on like, well, primary care physicians may not be expert in this field, and they have to cover a lot of things. But actually, there's some evidence that shows even nephrologists have not fully gotten the memo here in terms of the benefits of SGLT2, also GLP-1, right? Some of these other drug classes. So, what do you think's behind that? I don't know if we call it resistance, misunderstanding, where some nephrologists still have concern about prescribing this medication.
These are new drugs, and I think that clinicians are just getting comfortable with them. There are some side effects, and they're not for everyone. I think that's important to say. Genital urinary infections, patients who have trouble with those, it's important to say that's an issue. And I think very quickly for the patient, I would say blood pressure in general, less than 130/80 for most patients, talk to your doctor. Hemoglobin A1C, about 7 or less %, talk to your doctor. There are kidney protective medications. All your medicines are not equal for the kidney. ACE inhibitors and angiotensin receptor blockers for blood pressure. Those are like prils and sartans. Lisinopril is a generic ACE inhibitor. Losartan is a generic angiotensin receptor blocker. Those reduce the risk.
I'm going to trust our staff in chat to link some resources for that, so people don't have to have written all that down. Right, that's great for us to identify it, and if we can get in chat, so folks too.
So that's the blood pressure, ACEs and ARBs. For type 2 diabetes, especially, there are SGLT2 inhibitors. We heard about dapagliflozin, Farxiga. There's also canagliflozin, that's Invokana, and empagliflozin, that's Jardiance. Those are all kidney protective SGLT2 inhibitors. They reduce the risk of kidney failure, something like 30 to 45% in the different trials. I would say just roughly. It's some of the ways the trials look at it are. They use composite outcomes sometimes. So I would say these drugs are game changers, and we should try to use them as much as we can. And the last drug class is called finerenone. That's Carendia. That's also recently FDA approved. All these drugs I'm mentioning, ACE inhibitors, angiotensin receptor blockers for blood pressure, SGLT2 inhibitors, and finerenone, those are kidney indications. They're kidney protective medications. Finerenone reduces the risk of kidney failure by about 20%. The ACE and the ARBs, about 20% too. So all of these medicines, patients like Jane need to know that. And David, you need to know, because if you're going to stop one of your medicines, maybe because you've lost weight, don't stop one of these kidney protective medications. Stop one of the other medications. It's very important that you know that. And if one of the doctors wants to stop it, you should make sure there's a discussion about that. There's care coordination. And I think interdisciplinary care is the magic of kidney disease care. And we need to work together with our primary care colleagues, our endocrinologists, our cardiologists, and the patients will do better, I think, if they see a dietitian often or a diabetes educator. I think those are really important resources. Sometimes a pharmacist can be helpful.
So there's a ton in there that I think is really, really useful. Again, some great reference points that we can maybe anchor down in chat. Dr. Gavin, go ahead.
Yeah, I just wanted to maybe introduce a bit of a reality check as an appendage to Joe's comment. And you ask about why is it that we have what might be considered relatively poor penetration of these really fantastic new tools. I mean, let me make no mistake about it. I've been doing diabetes for 50 years. And as I never would have dreamed that we would have the kinds of capabilities to make differences in some of these outcomes in areas like kidney disease and heart failure that we're seeing now with some of these new tools, while at the same time treating the blood glucose of diabetes. And we should not take lightly the fact that we have training program inadequacies. Okay, our training programs for healthcare providers do not adequately emphasize or introduce some of these new tools. There are regulations in hospitals and in healthcare systems that don't allow their trainees to get exposure to the learnings that would ordinarily be brought to them by people, for example, from pharma, where they're developing these new tools. And then there are inadequate exposures to learning opportunities. Healthcare providers don't get the opportunity to go to the CMEs. We don't have nearly enough of them on a call like this, for example, where for many of them, this would have some new information, not just for patients, but for providers as well. And so the knowledge level, the familiarity, the comfort that's needed in order to make optimal use of these new tools, that's missing in far too many of our providers. And it just takes me back to square one. And that's why one of the agents of promoting this change that we have to make sure that we can count on are patients themselves. I'm done.
I would listen to you all day, Jim. We can talk afterwards. I want to hear more even. Okay. And one of the things that there are some barriers to some of these things. We're talking about training, but also one of the things that people bring up a lot is cost. Right, and you've raised cost to me, but Rachele, I want to come to you. How this is, how cost gets handled in terms of the development, obviously with Farxiga. What's available to patients? Are there ways to mitigate that particular obstacle?
Thanks for asking, David, because definitely that's one of the barriers. So I can tell you that at AstraZeneca, we believe that it's not enough for us to just make medicines, because the whole point is that we want to help the people who needs those medicines gain access to them. And we do have different programs depending on the needs. So for patients that have a commercial insurance, there are saving cards, and through those actually patient can get Farxiga in the specific case that was mentioned before for as little as $0 per month. For patients that have no insurance and limited income, we do have a program which is called AZ and Me, and we do have a similar program for patients actually that are enrolled in Medicare and are still having troubles affording their medication. Now, with regard to Medicaid, that's a huge percentage of people living in the U.S. I actually did check this morning. In the website that we have, it's farxiga.com. So all this information that I'm giving you is right there. There is an average out-of-pocket cost that is approximately $3 a month. There's coverage all throughout the states in the U.S., and some states actually offer lower copays or eliminate the.
Was that through these programs, through these patient assistance programs, or you're saying through something else?
This is actually Medicaid. It's
that's Medicaid. Got it.
That does not mean that there's no barriers related to cost of medicines in general in the U.S., which, to say the least, is not the easiest healthcare system to navigate.
Yeah, and we can't solve everything at once. But what I want to make sure is that at least within this specific field, people understand the first price that you see is not the last price, first of all, and that there might be resources out there. So and maybe to go back to like what my message is, right? And Jane, I want to jump to you here for a moment as we kind of finish this topic of intervention and how we treat, because I think your experience is so powerful for us to learn from. But I also want to make sure people understand, like, just because they hear a price, if there are resources out there that you might need to advocate for, go to the website, see, because Dr. Berria is telling us about a bunch of programs, that people may not be aware of, right? And that's just for one drug, for one specific drug, right? That each drug may have different kinds of programs out there. So it is a barrier, but it doesn't have to be the barrier, right? But I would definitely want to educate yourself if you're having trouble to look at some of those resources. Right? Jane, I've just been dying to ask here because so you're the one person amongst us here who's really like, you're in the, I mean, we're all in the fight at one level, right? But you've been in this fight. So just tell me, in terms of what you're using, what have you found to work for you, and what's been the most transformational pieces of therapy, pharmaceutical, non-pharmaceutical? What has been most impactful for you?
Well, first of all, I just wanted to say that I think the conversation about getting the education out to providers is crucial. I actually had to fight to get onto a GLP-1, which I have been on for 4 months now. And my nephrologist was very hesitant to prescribe that. So I actually went to my PCP, and they were kind of scared about having me go on it. But I got to tell you, it's been fantastic. And even with the cost of it for me, because I'm on Medicare, I can't do the subsidy kind of thing. What has happened is I'm not using insulin as much. So the cost of my insulin has gone down significantly. So it's kind of a balancing effect here from doing that. And my husband is also on Forxiga, and his sugar levels were all over the place, and he's using Humalog and all the insulin and all this other stuff, and he's cutting back too. So there's a balance in that for balancing the cost if you can't get the help. For me, it's an overall lifestyle that makes a big difference. And I think for any kidney patient at any stage, that looking at the whole picture, the whole body, what are you eating? What do you do? What's your stress level? What do you do for relaxation? What's your family impact? Are you a carb heavy family? I'm married to an Italian. They have red sauce for blood, and they eat bread forever. So there's a lot of changes, not just within yourself, but your family model that you have to incorporate. What's your physical activity? I have psoriatic arthritis, so I'm limited in some of the things that I can do. So what do? I go to a pool and I work out twice a week, doing stress exercises or strength exercises in the water. There are many, many things that you can do. Going to a plant-based diet was kind of difficult at first, and not that I was a big meat eater, but all the changes you have to look at, not just, I mean, it's very obvious. You look at chicken and fish, you know, you're not going to eat that anymore, but you also have to look at the protein that's in other products that you may not realize are in there. So you have to become a label reader. That is so crucial for good kidney health. Learn to read labels, learn to know what additives are, learn to know your numbers, know what potassium and phosphorus impacts are, and where you can limit those things just by what you put in your mouth can make a big difference. So those are, it's all encompassing. It's your whole life, but it does become just normal. That's my normal. So to me, it's like no big deal.
Yeah. And I love one that's been so successful, like the proof's in the pudding, right? Like it's actually, it is working. It's highly successful for you. Yeah. And to Dr. Gavin's point, it's like your expertise in you of what activity, what thing, you know, there was a question which fits in here. One of the questions from the audience, Mary Mowat said, if I drink more water, can I keep my kidneys healthy? How much water do I need to drink every day? And this sort of sounds like along the lines of what you were looking for. I'm curious if Dr. Vassalotti maybe or Dr. Gavin, you want to jump in on that.
I think in general, most patients can drink to thirst, and we don't necessarily prescribe a specific amount of water for most patients. That has to be individualized. Patients who have kidney stones generally need to drink a lot more water. And patients with certain kinds of kidney disease need to drink more water. But in general, I think for diabetes, I don't think we recommend that. And I'll just say can I just say one thing about cost for patients? Out-of-pocket costs are important to me and important to patients. And I think one of the things that we do is to work with a pharmacist and find out what the out-of-pocket costs are before we prescribe. Talk to your pharmacy. These are the 3 medicines that we could prescribe. Which one will give you the lowest out-of-pocket cost expense? And that will help for the patient. And, you know, it's frustrating for the clinician and the patient to have a $500 per month expenditure that is negatively reinforcing to one of these game-changing medication. So I think that's one approach, engaging your pharmacist to think about.
Yeah. And to Mary's question, drinking water, unless you buy that really, I mean, I do live in Los Angeles. The water here can be pretty expensive, but unless you're drinking really fashionable water, it's free, you know? So there are lots of things that I think you can do that are good for yourself. I promised we were moving to that the audience would get their questions. This is that time. So they're starting to roll in. We have a question, maybe Dr. Gavin, is metformin bad for the kidneys? This is from Pat.
No, I think that the important thing to remember here is that there's an organization called Kidney Disease International Global Outcomes, KDIGO, and they are the ones that are responsible for giving the recommendations for how do you best treat people with diabetes and kidney disease. And what they've recommended is that, you know what, you can use metformin, you just have to lower the dose. And then at the point where you have end-stage renal disease, obviously you can't clear it, so you don't use it. But it's a question of what adjustments you need to make in terms of dosing. And again, that's another one of those you become the expert kinds of things, because that information is something that you can talk to about with your provider, and you can also find that information yourself. And I should also add that increasingly, these kinds of recommendations are asking that you start SGLT2 inhibitors early, okay, as a standard of care. Because remember, they're not only treating the diabetes, but they're also helping those kidneys. So this is a good change.
And this is what you guys were talking about in terms of not all medications are created equal, right? So if you're looking to drop something in the mix, you might be able to shift, if you will, or keep the protective meds in place, right?
Yeah.
So we had a question from Marie. Do low blood sugars affect the kidneys?
Well, I'm not sure that there's any direct information that, you know, hypoglycemia has an effect on the kidneys like they have on the neurons of the brain. But obviously, there's no good that comes out of exposure of any of our organs to prolonged periods of low blood sugar. But the direct evidence that you get some necrosis or anything like that, I'm not sure that there's any evidence for that. But nevertheless, avoid it. That's the bottom line.
Got it. Yeah, for many reasons.
Can I just say what the only thing I wanted to add there is that people with kidney disease and diabetes should know that hypoglycemia is the most common patient safety issue for people with kidney disease and diabetes. Type 1 diabetes and type 2, the insulin is cleared by the kidney. So when your kidney function decreases, your insulin lasts longer and you're more likely to get hypoglycemic. And some of the oral medications also are cleared by the kidney from the body, so that they have a more potent effect as your kidney function decreases. So your risk of hypoglycemia increases as your kidney function falls. And that's very important to know, to try to avoid it, and to work with your doctors. You might need to lower your insulin dose or some of your other medication doses as your kidney function falls.
Yeah,
I'd never heard that. It's really, really quite interesting. And actually, you know, things that look good, like, oh, insulin's down, right, which is a success at one level, can actually have other things. Now, if you're not tracking the complexity of it, right, all these different numbers, quite interesting. So Robin's asking about inheritance, right? Can inheritance play a big part in CKD when a parent dies from CKD without having diabetes? So what's that inherited link? If any of you want to jump in on this.
Well, that's a nephrology question. So I'm going to let Dr. Vassalotti talk about genetically driven kidney disease.
This is the free consult with the nephrologist that we all wanted, right? You couldn't get referred in your network. We have Dr. Vassalotti here.
Well, it's important to have understand your family history. If you have a family member who was treated with dialysis or a kidney transplant, for example, that's important to discuss with your care team. We have genetic testing for kidney disease now that's widely available. That might be worth pursuing. It might not change your care, but it might help you understand what's wrong. And if you have children or relatives, it might help them understand if they have kidney disease too. So I think that's where that would be relevant.
Can I just add here, because I'm not sure whether the question is implying this, David, that if you have a family history of some kinds of genetically driven kidney disease, and then you have diabetes, there's nothing to say that you don't have both a risk for that genetic component of kidney disease and diabetic. or diabetes-related kidney disease. So that may be a more complex iteration of that situation.
But it sounds like another one of those know your risk factors, right?
Yeah.
Like, oh, okay, I've got this in play, I've got that in play. Maybe get a little bit more aggressive about asking for that test, right? Like, what is the test? What's the number, right? That you want to get out ahead of some of these things, just to think like, well, I know I'm at risk, right? So I should be a little bit more aware.
And this is another argument for why genetic variants and determination of genetic makeup becomes important, because we need to know how to do precision medicine and know what makes this person at risk for which of these outcomes.
Yeah. We're in the end, we're really looking for accuracy, right?
Correct.
And getting, and not, by the way, not over diagnosing, but frankly, we're not really
precision in diagnosis.
Right, but we're not really at risk for over diagnosing kidney disease at this point in time, right? That's not really a big fear, right? Let me just because I think all the risk factor stuff is intriguing, and it's really about like a lot of what James has talked about in terms of like being able to have conversations, like understand her particular situation to figure out what's working for her. But I want to jump. There's another question from the audience. Should I see a kidney doctor in addition to an endo?
Yeah, I think that's something you should talk with your clinicians about. I think in general, if your eGFR is less than 30, it's recommended to see a nephrologist. If your urine albumin to creatinine ratio is more than 300, I think it's worth considering. One of the questions I think that's worth speaking with your primary care doctor about is diabetes causing my kidney disease? That's very important, because I think Dr. Gavin is alluding to there might be other causes of kidney disease other than diabetes. And in general, if you have high albumin in the urine, and especially if you have retinopathy, diabetic proliferative retinopathy, that microvascular disease, we call it, tends to go together with diabetic kidney disease. So if you don't have retinopathy, or if you don't have albumin or high albumin in the urine, if you don't have both especially, that might be a reason to think about seeing a kidney doctor to find out what the cause is. If you can't take an SGLT2 inhibitor, or if your doctors don't want you to take, or don't know how to give it, or afraid to give it, that might be a reason to see a kidney doctor that can give it. And especially if you're having trouble managing your care and you have kidney disease, I think it's worth considering seeing a kidney doctor.
So I want us to wrap up a little bit. There's a lot of things here that I didn't know I was so interested in kidney disease, but now I know. Thank you all for bringing this together. But I want us to maybe have a little lightning round, right? So I want everyone just to take maybe 30 seconds each to talk about what piece of advice you have for people who are at risk for chronic kidney disease. Like, bottom line, what piece of advice, including those with diabetes, right, to prevent the progression or slow the progression of the disease? Maybe Dr. Vassalotti, why don't you get the lead spot as the resident nephrologist here?
Okay, so I think if you have diabetes, you want to make sure you get that test annually, the estimated GFR, the blood test of kidney function, the urine albumin creatinine ratio. That's the kidney. I like to call it the kidney damage test. Know the results. If they're normal, repeat them every year. If they're not, what can you do about it? Healthy diet, dietary patterns more than, evil foods or beneficial foods, just your overall dietary pattern, physical activity, and think about those kidney protective medications that we talked about. The ACE inhibitors, the angiotensin receptor blockers for blood pressure, the SGLT2 inhibitors that are type 2 diabetic drugs, but they're kidney protective, and something called finerenone that's really like a blood pressure medicine, but also kidney protective and heart protective. And those are the things I would think about. And then ask your primary care doctor, is it okay for me to be cared by you, or should I see a kidney specialist or not?
That's great. That's great. Dr. Berria.
So my advice would be, and it was a common thread in our discussion, know what your risk factors are. And the great news is that with those actions, you can prevent or better manage your heart disease, your diabetes, your kidney function. The second advice I have is, especially now that you might be thinking about your New Year's resolution, don't be afraid of taking health into your own hands and ask your doctor about your kidney health.
That's good. Now you've got me thinking I have to reevaluate my. I thought it was just watch less football. but maybe I need to be a little bit more dedicated.
Maybe both.
Maybe both. Maybe both. It's probably not good for my kidneys. Jane.
My advice is to be the captain of your ship. Make your health team work for you. You are the center. Make sure that they're all talking to each other, including you. Ask your questions. Go to your providers prepared. Have your questions. Know your symptoms. Keep records and diaries of what you're doing, what's going on, so you don't kind of get that white coat. Oh my God, I don't know what I want to talk about now. And he's got 15 minutes and he's out the door. Be prepared. And if you need to get some support, the best place to look is to peers, and the NFK, National Kidney Foundation, has a wonderful peer mentor program where you can get paired up with somebody who has CKD, probably close to any other kind of comorbidities or other conditions that you have. So you can talk with somebody who's walking the walk with you. And it's a great way to get educated and learn other resources.
Fantastic. Dr. Gavin, you told me you were done 10 minutes ago. You said that was it. And you're not quite. Bring us home here.
No, my colleagues must have been reading my notes, because they have actually summarized my notes on this far better than I could, because this commitment to becoming an expert in that one case of kidney disease and its risk management, that is the case of yours. Know what your risk factors are, how to manage them, what tests you need, what numbers you need to know, what constitutes good, what constitutes bad. Comfort with being the captain. That's what being that expert means, that you have complete comfort in being the captain of this team. And of course, it gives you the right, it gives you the prerogative to ask, because now what you're asking is also driven by information that you have gathered from the best possible sources. That's what this expertise in a case of one really guarantees. And so I think that my colleagues have said it well, and I would thank you all for the honor of being a part of your discussion today.
Yeah, well, thank you. Actually, thanks to all of you. I have to tell you, I'm certainly smarter on this issue. You may not know that I was pretty nervous coming into this one because it's an area that I was pretty in the dark about, and I feel a little less alone after all this, and I feel certainly better educated on it. So I appreciate all that you're bringing. I want to thank everyone who's joined us. All of you in the audience have been a huge part of it. Thank you so much. Also, as a reminder, we'll be staying online here for about the next half an hour, right? So that'll give you some time for the community networking and to visit the expo booths. You can continue to interact here. And you can do both of those things by clicking on the icons. Actually, it's the icons, I guess it'll be over here on the left side of your screen. You can get into those there. If you haven't completed the polls, click to them now. Finish all those polls would be a great service to us. Thank you all for your participation. Thank you to our panelists. You guys really, really rock. And everyone, stay safe and stay well.
Thank you.
Happy holidays, everybody.
Happy holidays.